Thank you, everybody, for joining us on this Tuesday evening. I'm Brian Rose. I'm the current president of the Academy of PAs in Cardiology. I have the privilege of being joined by my colleagues across the country this evening to talk about case-based approaches to optimizing diuresis in patients with heart failure. Viet Le from Utah, Craig Beavers from Kentucky, and Jessica Saliba from the Sunshine State of Florida. All right. All right. Special thanks to this evening's sponsor, scPharmaceuticals. And what I'd like to do is offer an outline for this evening. First, we're going to recap issues leading to hospital admissions and readmissions related to heart failure. Recap the congestion dilemma that we covered during our part 1 webinar just a few short months ago. And lastly, what will be most unique about this webinar is talking about real-world case-based examples of where we use Diuresis in our everyday practice. So 6.7 million individuals had heart failure in 2019. Number one cause of hospitalizations for Americans over 65, and 25%, and probably this is a conservative estimate, of those patients are readmitted to the hospital within 30 days. Rather soberingly, 8.5 million is the projected prevalence of heart failure patients by 2030. This will equate to about 1.3 million hospitalizations annually, and 1 in 14 patients will die within those first 30 days after discharge. This is a chart that shows the disease progression of patients after each subsequent decompensation. And what it shows is that after each hospitalization, the patient's mortality rate increases, okay? And congestion is the driver of this. Congestion affects patient outcomes. At time of admission, 89.7% of acute heart failure patients were considered wet at time of admission or volume overloaded. Unfortunately, we have very subjective ways of looking at congestion, and those patients, up to 36.5% of them that were admitted with acute heart failure, are still wet at the time of discharge, putting them at great risk for readmission. This is the continuum that we all struggle with when we see patients in the clinic post-discharge from a de novo heart failure hospitalization, or patients with chronic heart failure that we're trying to keep out of the hospital. And what I want to point out here is the continuum that starts all the way almost 4 to 5 weeks before symptoms appear, where we have hemodynamic changes, where filling pressures increase, there's autonomic adaptation, intrathoracic impedance, and then the patient presents with weight change and symptoms. And unfortunately, a significant proportion of those patients proceed to hospitalization. Unfortunately, and what is really one of the main objectives for us to talk about this evening, is getting the patient back down this continuum to where they're hemodynamically stable. So diuretics are the mainstay of treatment, both in acute decompensated heart failure and chronic heart failure management. But we're seeing a decreasing use with effective GDMT, which is a good thing. Loop diuretics are the agents of choice, but it's not always a straightforward answer. Which agent do we choose? What's the dose? Diuretic resistance, which is found in 30% of patients, can develop, requiring either escalation or adjunctive therapy. And I want to draw, this is borrowed from Dr. Dan Ben-Simone out of Cone Health in Greensboro, this idea of pseudo-resistance versus actual resistance. And this is very much in play in everyday clinical practice. On the right side of the screen is the most recent ACC/AHA Heart Failure Society guidelines, showing that in any stage of a patient's heart failure journey, assessing their clinical congestion, and more importantly, their need for escalation or adjustment of their diuretics is always in play, all class 1 recommendations. Outpatient diuretics are a slippery slope, for sure. Fewer than 1 in 5 hospital systems have the ability to administer IV diuretics as an outpatient. Staff, equipment, time spent are real considerations of being able to use this as an effective tool. Usually, single dosing strategies are ineffective, and we'll talk about that a little bit later in our individual experiences with that. And as I alluded to previously, despite using IV diuretics, 50% of these patients go on to hospitalization. What you can see here is the varying bioavailability, the ratio from oral to IV. And I won't steal Craig's thunder. This is your wheelhouse, so I'll let you get into that a little bit later. And in the bottom right is the Transform HF trial. And this just kind of shows you there's really no difference in these patients from an outpatient setting. So this is really, truly a call to arms to do something different. So what's different? This is another tool used for decongestion that's not IV diuretics, okay? And Furosix. This is a pre-filled disposable cartridge. It delivers 80 milligrams, a fixed 80 milligram dose of furosemide, 30 milligrams in the first hour and 12.5 milligrams per hour for the next 4 hours. There's visual and audio feedback for the patient, and this is very much a patient-centric design. So with that background, a little bit of recap about what we talked about last time. This really kind of sets the stage to get in some case-based discussion. So I'd like to hand the reins over to Craig. To walk us through the first case.
Sure. And I am excited to be here. I thank you all for the opportunity. As Brian alluded to, my name is Craig Beavers. I'm a cardiovascular clinical pharmacist who practice in heart failure with Baptist Health System in Kentucky, and also an adjunct associate professor with the University of Kentucky College of Pharmacy. So I'm excited to kind of present this case as a case that similar, but I modified it to make it a little different, but have the same feel and flavor, and not be incriminating for any purposes. But it's a 40-year-old male. He is a patient with a new diagnosis, or at least new to us diagnosis, with heart failure with reduced ejection fraction. His EF is 20 to 30%, who is 5 days out from being discharged from acute decompensation. And that is obviously the place where we discovered his new heart failure. And he's here to present to the Transitions of Care Clinic for us to kind of optimize him, do we see all of our patients within 7 days. And then we start them on their journey towards GDMT and whatever other resources and activities that we need to do for them in this process. It's a multidisciplinary clinic. We have myself, I have another pharmacy partner. We have advanced practice clinicians and a cardiologist, amongst other team members who work with us. His heart failure with reduced ejection fraction is relatively recent, as I alluded to, but the probably inciting cause, or the most likely inciting cause, is he is have been positive, or at least tested positive, on his admission for methamphetamines, and admits to using them regularly due to a kind of bad social situation that he has been in from that standpoint. And so this is most likely a drug-related or induced cardiomyopathy, but it, is really impacting his ventricle and his effort, and has led him to this decompensation. He is actually willing to seek help and kind of move in that direction and get him, in the ability to be clean for a variety of different reasons. And so he was definitely interested in attending with us. But the interesting thing is, the reason he ended up leaving the hospital is he left AMA because he did not want to stay in the hospital. And I know that probably gives everyone pause, if you're talking about somebody who has illicit drug use and them not wanting to be there and so forth. But his actual motivations was really trying to be with his kids, or at least that was the state at the time. But he did follow back up or attend his clinic visit at that particular juncture. And so after being managed with the furosemide drip during his admission, he was discharged or left AMA, and he was given furosemide 40 milligrams daily, carvedilol 3.125 PO twice daily, and losartan 25 milligrams daily. And of course, we told him when he was leaving AMA, because our heart failure navigator had already set all this up and talked to him, and we had the suspicion, and she had made a strong relationship with him to do this. And so his weight on the day of discharge was 55 kilograms. He was 60 kilograms on admission. His heart rate was 60 to 80 beats per minute range, and his blood pressure was 105/74 with a serum creatinine of 1.2 and his NT-proBNP of 3,000. Next slide. So when he presented to us on clinic, he appeared to be have shortness of breath and fatigue. He was burping a lot, which indicated to me probably had gained a decent amount of fluid back into his gut area. And he had 1 to 2 plus pitting edema. We do REDS readings on all of our patients, if you've not heard of the REDS device. So we use that as another tool to assess our fluid status. And he was in the 40 percentile range, which is somewhat elevated or indicative that he had fluid on his lungs. And his blood pressure is still hovering around in that hundreds to 105, 65 to 76 range. Heart rate 60 to 70 beats per minute. His weight had gone up actually higher than what he had presented to us somewhat on admission. And likely the chances are he didn't get fully adequately. I mean, he was making progress, but probably had more to give and reverted course. And his creatinine indicated also to us that he had obviously seen some decreased perfusion or weight gain from the fluid, and his NT-proBNP had increased, and all his other labs were kind of within normal limits. And he did admit to being adherent to his other therapies upon discharge. He just would prefer not to go back to the hospital. He was very adamant that he did not want to go, that he would not go back that way, even if we recommended it. And you can't obviously force him to go there from that standpoint. But he said if he was forced to go back to the hospital, he would not come back to clinic, and he just did not want to be in that environment. And so that's kind of the predicament we're in. He clearly needed some form of fluid status or process from that standpoint. Next slide. And so this kind of, back up. Sorry, I thought there. So this kind of left us with a predicament, and we can kind of discuss this. We just to give you some context, we are a clinic that offers IV diuretic ability into our process. So we do allow or can give IV diuretics within our clinic. Now, given other logistics, whether people have to travel or other concerns, that's it depends on the patient and the process from that standpoint. So that way you understand all the tools we have available to us in our particular environment. So I guess I'll pause there and open it up to anybody else on the team to see what their thoughts are. And then I can most certainly tell you what we ended up doing as a part of this process. So,
yeah, Craig, first question, and we'll definitely, I think, I got an idea. Let's actually have everyone kind of open. Keep your questions coming in the chats, and we'll save some for the end, and then we can have a good panel discussion at the end.
Sure.
How about that?
Sure. However you want to do it.
Okay.
I'm here to be the guest, so I'll do whatever you want me to do. So.
Okay. Wonderful. Yeah. I do have one question for you. Did when you saw him in clinic again, did he admit to using again?
So interestingly enough, he did use again. However, he, not to get too much into the context, the living situation is not someone that he was living with, a parental unit, was actually the supplier. So he has this confliction piece, and we were working to remove him from that environment. But he really did want to actually, he really was motivated by a lot of his other social drivers. And so he really was at least presenting this to be sincere, not to jump to like where he is now, but he has actually been consistently clean since then from that standpoint.
Okay. So definitely keep the questions coming on Craig's case, and we'll do some rapid fire at the end. How about that?
Sure.
Okay. I will transition to my esteemed colleague, Viet.
Hey, sorry, I was kind of mulling over REDS. As that was one of the questions in there, but because we don't use it at Intermountain, or at least not in my clinic. So that.
But you're aware of it, right?
Yeah.
Okay.
Yeah. So so let's swing all the way to the other end of the age spectrum, like doubling the age of this 40-year-old, and we'll use HFpEF. So for, everyone that is on the webinar, thank you again. I'm Viet. I'm a preventive cardiology PA. So why am I treating heart failure? Because we treat everything in preventive cardiology. And by the way, come see me this weekend at Heart Failure Society. Annual.
I'll be there too, Viet.
Yes, awesome. Yeah, we'll do some selfies. Um, so this lovely gal, whom I've been treating for a long time, amazing 80s, and just on the edge when we first started this, and so she's now in the nifty 90s. So heart failure with preserved ejection fraction and pulmonary hypertension, so EF 57%, diastolic dysfunction, of course, very stiff looking heart. And for GDMT, this has been difficult. She has CKD stage kind of 4. So it's rather difficult when we think of GDMT, especially MRAs. It's been off and on, no current RAS or SGLT inhibitor, despite conversation. It's not like I'm reluctant for SGLT inhibitors. However, the discussion in terms of someone in their 80s, where do we go with that? So that's a kind of a different talk. But mainly, we've been managing her with diuresis. She's been managing herself with diuresis very well, thank you very much. And so severe tricuspid regurgitation, had a TriClip. You can see here 3B4, and then just bouncing all over the place with electrolytes. It's so difficult when you're managing CKD and using diuretics. So chronic hypokalemia, moderate hyponatremia, and then on top of all of this, right, permanent AF, really can't be on any type of anticoagulant, bleeds in the past, so does have a Watchman device. And then added to this is this prior history of tobacco use leading to COPD, asthma, and then daytime hypoxia here. So, in the settings, if you'll, next slide there, Brian, really has been living on her own, managing herself. And then despite direct text phone access to me, if you know me, all my patients have my cell. And so we've been managing, any questions, any thoughts that patients have, they'll text me, and I always let them know, hey, I might not be able to get to it then, we'll get to it at the end of the day, but often I can respond quickly. So managing oral diuretics, she just experienced several heart failure hospitalizations. And when I say several, in your 80s, think back to Brian's slide of mortality as you continue to bounce in and out of the hospital. So her symptoms really just 2 through 4 throughout the week, depending on how she's managing it. And after just so many different changes to her diuretic regimen, as you've mentioned, she went through furosemide, down to torsemide, then bumetanide. We're adding metolazone, just all sorts of things. And then remember, CKD, late 80s, and she's managing this fairly well, bad, I don't know. So next slide, as we think about this was the gal who led me to create my own IV protocol, IV outpatient Lasix protocol. I'm like nested right inside next to my heart failure clinic, and they do outpatient IV Lasix in the clinic, but I don't have access to that room because I can't use their nursing staff. And so I had to develop this with our outpatient, just next door, next building. The infusion clinic was very happy to work with me. So after these recurrent hospitalizations, she was having one, again, I've managed her for quite a while. And I didn't have more hair then, I've been bald the whole time. But once every 2 to 3 years, she would have these hospitalizations. And about 3 years ago, this variable course where just 3 hospitalizations in as many months. That's what led me to develop this outpatient IV Lasix protocol. And, to your point, Brian and then Craig, really doing it once is not enough. Doing IV Lasix just once, one and done, it's not enough to diurese well, or to keep them from just kind of almost bouncing back. It's almost this pseudo discharge from the hospital where you haven't gotten enough fluid off of them. So doing this and then using oral torsemide plus minus metolazone we finally got her from rehospitalizations. That did it. So for the past 2 to 3 years, really doing this IV Lasix was helpful. But remember, she lived alone and would require family to bring her into the IV or the outpatient infusion clinic. And the problem then becomes transportation, consistent transportation, but incontinence. It doesn't take long to do an IV Lasix treatment, but they still have to get home. And depending on when that's scheduled, an accident happens. And we're not talking car accident, although, I might have an accident that way too, if I had an incontinent episode. But it was about this time that I discovered FUROSCIX, and you can see, cough, cough, took me about a year to really kind of wrap my head around how am I going to use this? What ways will that help in this patient? So there was some treatment inertia on my side in thinking about this. So let's go to the next slide here. Nifty 90s. So as we kind of transition, she was right on that late 80s and into the 90s. Again, IV Lasix required help to transport her, making it home in a reasonable time in anticipation of that diuretic effect. It was one of those non-patient centric things, more patient centric than being hospitalized to be diuresed, but difficult to get home in time and transfer from the car back into the house. You imagine the last time you had to go to the bathroom and your zipper wouldn't go down, or you couldn't get your belt or whatever, and just trying to make it from the car to the house is difficult. So here we converted her. And I don't know that, I don't know, Brian, if you want me to kind of get into that piece of it as much right now, but suffice to say, she no longer needs that transportation. She can do it in the comfort of her own home. She has demonstrated that she can manage things like torsemide plus minus pitolisone, and now she doesn't have to go to that route. Although occasionally she does. She texts me and says, "Hey, I used metolazone. I didn't have to use my FUROSCIX, etc." But I think what I would like to hear from my partners here is their thought on potassium supplementation in this setting, because I think that's one of the concerns that a lot of folks have, right or wrong. They have a question of like, well, crap, if this is as good as IV Lasix, and I know what happens in the hospital when I use IV Lasix, and we're having to kind of double doses of potassium, et cetera, to kind of keep them. And I've already mentioned she's kind of this chronic hyponatremic and hypokalemic kind of person. So it's one of those things that I think we have to navigate and do it well. But I want to leave it there and give time then for Jessica, and then we can kind of come back to how she was managed on FUROSCIX, if you'd like.
Absolutely. Wonderful. And then, of course, I included your labs.
Oh, yes. So you can kind of see here, bouncing up and down. Actually, we had gotten her a little bit better there on the far left column. You can see her sodium level, potassium. That's been actually okay, throughout all of this, including IV Lasix and then into the FUROSCIX era. If anything, she bounced high a couple of times. But anyways, thank you.
Well, I think the proof is in the pudding here, so we'll have to kind of unwind that a little bit later about what your approach was to supplementation there. Jessica.
Hi, everyone. I'm Jessica Saliba. I am a nurse practitioner. I work in Jacksonville, Florida for Baptist Health System. It's a community hospital. I run our heart failure clinic. I work in our most urban population, so lots of low income, very difficult, complex, older patients. And so I love FUROSCIX. It has been becoming my #1 favorite medication with these hard to manage, constantly rehospitalized patients. We were asked to do case studies, and I had so many. This one here that we're presenting is a lady, I've known her for about 6 years now, and recently in the last 3 years diagnosed with Parkinson's, and it's progressing rapidly. So we're having lots of complex issues come up with trying to manage her. She's a 75-year-old female. She has heart failure with a reduced EF. She had severe mitral regurgitation, which we repaired in 22 with the mitral club. She's had PCI to the LAD. She's had multiple recurrences of AFib with multiple ablations. She most recently, in the last 6 months, has developed atrial flutter, which we're trying to handle right now. She's got a pacemaker. She's had pericardial effusion. She's got PVD, hypertension. She's had a stroke. And then because of her Parkinson's, she gets this autonomic dysfunction with orthostatic hypotension. She fell, unfortunately, and was on Eliquis. So she had a brain bleed. She got a subdural hematoma and a burr hole. That was about 3 months ago. And so lots and lots of things going on. The mitral valve, I know we clipped it in 22, but here we are in 25. It's now moderate, almost severe again, unfortunately. She's had back-to-back hospitalizations. She was doing so good, I didn't see her for about 6 months. And then all of this happened about 3 months ago. And it's just been one hospitalization after another. We've been talking through our patient portal regularly. We've been trying to manage her. Her son-in-law was able to bring her to me about a month ago. And he's like, listen, she keeps filling up with fluid. What are we going to do? Because every time everyone's scared of the, autonomic dysfunction and they keep stopping her diuretics. And then the nephrologist gets worried about the renal function. So we have been using Furoscix intermittently. When I use the Furoscix in my setting, I don't have the patient take the oral diuretic on that particular day. So I keep their potassium dosing what they normally do with their oral diuretic, the same as the Furoscix. And then I check labs about ideally within 3 to 5 days after they use it, just to make sure our electrolytes are okay. Luckily for her, I've been able to get our home health involved, so they've been able to come out and draw her labs at home, because again, transportation is an issue. So her electrolytes thankfully have been holding steady, but this autonomic dysfunction has been very challenging. So I was able to introduce some midodrine, not my favorite drug in heart failure, but we have to keep her out of the hospital. She begged me, she has a dog at home. She wants to be at home. She does not want to go back. So when her blood pressure, if she knows she's going to use Furoscix, if her blood pressure is under 100, she goes ahead and takes the 2.5 midodrine, waits till the blood pressure is over 100, which usually once it kicks in about 45 minutes to an hour later, then she's able to use the Furoscix. And on those days, she stays at home. She doesn't go anywhere, tries not to get around much. We've done all the fall precautions as much as we can. Obviously, she's off oral anticoagulation. She actually had a Watchman about 6 weeks ago. So, we're doing all the things to keep her stable. And so she's been home now about 3.5 weeks, which is the longest she's been home in the last 4 months. And she is so ecstatic to use the Furoscix. She's been telling all her friends, which I have some of her neighbors that are my patients too. So this has been a hot topic coming into the clinic, but we're excited to have it. I'm trying to get more and more of our practice on board with it. Usually if the doctors are thinking they want to use it, they just tell them to come see Jessica in Heart Failure Clinic, because I really do follow these patients very closely. I call them the next day to make sure they're doing okay after the Furoscix, make sure it's worked. I know per the label instructions, you could do it every 12 hours if you needed to. I've only done that a couple of times, I'll be honest, usually just doing this once or twice, like maybe a couple of days in a row, and then maybe doubling the oral diuretics a couple of days has been all that I have needed to use so far to get these people out of the woods, back on track, and keep them at home. So sorry, I kept it really short.
No, that's perfect. I think, I'll make a little segue and before I talk about my case. A lot of times when we think of new drugs and we hear about new therapies and there's cases attached to them, they're almost kind of like, I call them cookie cutter cases. These are not cookie cutter cases. These are real world. These are tough. These are sometimes where the patients have seen other cardiology providers along the way. Like we've all said, recurrent hospitalizations, we know what sort of statistics these folks are up against. So, I mean, these are tough cases, and I really want to kind of highlight that for our audience is these are very medically complex patients that we've been talking about. So let me add another layer of complexity to it. So I'm Brian Rose. I am in southeastern North Carolina. I'm affiliated with First Health of the Carolinas. I was in private practice for a number of years and recently got out. I do general cardiology, but one of my main areas of interest is heart failure, obviously, but pulmonary hypertension as well. And it's an area that I kind of fell into a couple years ago by happenstance, because I tell folks that I had a patient, one of my patients kind of bullied me into it because of access. So it really kind of was a call to arms. So this has turned into a passion of mine that I've really have embraced. And there's not a lot of us that take care of this disease. So it's a small community, but significant overlap with heart failure. So this is a 70-year-old lady who I actually just saw a couple weeks ago. 70-year-old female admitted for heart failure with obvious volume overload. I remember the day I saw her a few years ago in the ER for the first time. Her BNP was almost 5,000. She has a history of coronary artery disease with a prior stent, hypertension, hyperlipidemia. I should mention she's about 4'10". Okay. She's got lymphedema. She's got, those classic tree trunk legs, weeping, some superficial ulceration, some underlying venous insufficiency as well, diabetes, and a prior stroke. She reported a 20-pound weight gain from her baseline. Okay. So someone who's 4'10", 20-pound weight gain is pretty significant. Progressive dyspnea over the last several months. She noticed increased exercise intolerance and more edema than what she is used to with her baseline lymphedema. So her echo showed a normal LVEF of more than 55%. RVSP was mildly elevated. RV systolic function was mildly reduced. RA dilatation. This is an apical 4-chamber view, and what you can see is this right heart is huge compared to her left heart. So this is a lady we took for a right heart catheterization. In crash course in hemodynamics, we won't break it down, but this lady has group 1 pulmonary arterial hypertension. Okay. Current medications that she's on, at least as of today, is sildenafil, macitentan, and Uptravi or Sexlopeg. So she's on 3 different types of vasodilators. Okay. My point with her is she was, despite having pulmonary arterial hypertension, she has developed significant right-sided heart failure and congestion and symptoms. So this is a lady that I've used Furosix in and have successfully been able to keep her out of the hospital. And now we're moving on 2.5 years, and she uses Furosix once or twice a month. So this is, I'll be happy to field some questions on this case, because, this is not your stereotypical HFpEF, HFrEF type patient. This is somebody that has a pretty terrible disease with a very bad long-term prognosis that is being complicated by heart failure. Okay. So what I'm going to do at this point is, Craig, let's go back to you.
Sure.
What did you do with that patient?
Sure. And real quick before we jump into that, and by the way, what a great diverse degree of cases and things and experiences. So, I don't know if any of you guys have any additional questions. So, obviously we weighed the different options. And as I alluded, I kind of had, and they deleted them as like, would you send him back to the emergency room despite the need for what he wants there? Do you try him on IV diuresis at home? And I think Viet did a very nice job, or not IV diuretics in our clinic. I think Viet said a very nice job about the logistics of that, is not necessarily just the incontinence piece, but realistically with him, we suspected, and I think Brian, you've alluded to this, and yet he's going to need more than one dose, right? And that means he has to come back. Like, we know that this one shot is not going to maintain him either today or the next day, or it's going to be a long and arduous process. And getting that type of commitment was going to be an interesting piece from a logistical standpoint for him. But we wanted to try to meet him in some way to to see if we can manage him. So we actually did do a dose in the clinic, a dose of IV diuretics, but then sent him out with Furosix to have at home to kind of mitigate his strategy to provide his ability to have him not go to the hospital, and then actually followed him up. We did the dose during the clinic day, had him do another dose or start the Furosix the next day, and did that for a 3-day period, had him come back in, check to see if he was moving in the right direction in terms of where we wanted to see and in terms of his weight and his process. And then obviously that did a couple of things for us. Not only were we able to manage his fluid status, it provided us a little bit of extra opportunity to be like, look, we're going to check you every time you come back for your use, to hold him accountable, like, as you're doing a part of this process, if you really are committed to this, and as we wait to get him into more of a long-term program to get him moving in that particular direction. And so we did that for a several day period, and actually did see some progress in terms of his weight over that 3-day period. Went back down to the 60 kilograms that he had started out. What his weight was when he was at the hospital. Of course, he had gotten lower at that particular juncture, but he responded quite nicely. And so then we continued providing the Furosix for the next several days to get him into the next, following. If we saw him at day 5 upon his discharge, we started that process on day 5. We did that over a weekend with the Furosix piece, had him come back on Monday, and then we did that for another 3 days, saw him in the middle of the week, and saw that we had gotten him, somewhat back to his drier weight from that standpoint, and we're able to hold him accountable as a part of that process. So that's how we kind of mitigated that process. Interesting enough, I think Viet alluded to something about the potassium, and you guys were all talking about that. In kind of the interim game of that process, we actually had started him on spironolactone, partly to help us be a little proactive in mitigating that potential piece of the strategy. And he was, able to maintain it. I think with the way that the Furosix diuresis is, the potassium changes is not as dramatic as what you would think it would be. It kind of stabilizes out, but for just some added benefit and knowing that we were going to be seeing him pretty regularly over the next course of the week or so, even though despite we hadn't actually fully he didn't have a lot of room to tolerate his beta blocker changes at that particular time. We didn't want to send him into another type of decompensation. We didn't want to increase his losartan or change him to ARNI yet because we hadn't gotten him to where we were confident with his blood pressure yet. And so we were like, we'll go ahead and do his MRA at this particular juncture, provide that extra kind of help with the potassium regulation piece. And he navigated it pretty successfully from that standpoint. But
Craig, you touched on something. Viet, this question's for you. You're a very accessible clinician to your patients with giving out your cell phone number to anyone who asks for it. How do you see this as a tool? Craig alluded to it, for patient buy-in, really kind of taking ownership of their disease.
Look, we do a lot to the patient without really almost no consent. Really, we do a lot to patients, and we say informed consent, but we're really like, this is what we're going to do to you. Just sign this thing. And inherent in a discussion with someone that has methamphetamine driven HFrEF, it's already come up. There's this kind of yes, there's a pattern, but there's implicit bias of like, are they going to hold to their therapy? Are they, and you've seen this. I mean, you've been in environments. I don't see as many of those patients, but at the same time, Buy-in comes from putting them in the driver's seat. I think really if you let a patient know, like, hey, congestion's not good. You certainly don't want to be in these four walls and have us consistently sit there and watch you and wake you up all night long and weigh you and measure your pee and all of that. So here's a way for you to be able to do this at home, feel better, as you decongest, but also you're in the driver's seat. And so for me, I really like this Furosix. Even IV Lasix has been a fantastic way to place patients in the driver's seat, because when they come to me, I'm like, hey, look, we've got some options here. It's easier to like me to dump you off to the hospital and let them kind of sort things out, or let's kind of think through this. We've got IV Lasix in next door. It takes some work, but then you're able to go home, watch your dogs, be it if you're primary caregiver that's also ironically having to take care of yourself, then Furosix just really adds a great layer of keeping the patient at home and then being able to interact with them. It sounds like, Jessica, you have a great way of being able to message through the chart with your patients. And I'm learning that through Epic. We just went live, and I'm liking that.
I like that.
Yeah. So it's been really nice. It was a little clunky in our older EMR, but here it's been nice to be able to have that option to talk to patients through the chart rather than giving everyone my cell. It's still something I do. It's there's this layer of like, wow, you gave me your cell, and no one really abuses that. But at the same time, they know I mean business. Like,
Yeah,
I'm here for you, man.
well, and to your point, a little bit of and I want to call it either shared decision making, kind of motivational interviewing, or informed process we did. And I don't want to say he was a unique individual, but he did have some real motivations, and his explanation for how he ended up in the scenario he had is he was inadvertently being pressured by his parental unit for this piece, and he really wanted to make the change. However, the thing that we talked about is like, look, if you really are being sincere about this, your options, if you continue, are not going to be as promising, and i.e., like, you will probably not get a heart transplant and or be able to be listed for even IV inotropes, for that matter, just from the things that you were alluding to. And so we did kind of have that conversation, like, you're going to have to, if you don't want to go to the hospital, which we appreciate that concern and that process, you're going to have to be willing for us to be creative with what we're going to do for you. And that's going to require you to be, pretty adherent with us. Now, we weren't going to say you have to come back every single day. Now, obviously, if he couldn't have gotten the Furosix or something, and we were able to get that for him, we would have had to come up with a different strategy. So I think the thing is you're always looking at this through the lens of what the patient is going through, whether they have access, availability, and the things that you can meet them along the way. I will tell you, we're fortunate, or it has been very helpful for us, because we live in a little bit of a rural population or rural area, and sometimes it is challenging for people to get back to our clinic and to do diuresis if we need to do that. But we also don't want them to be readmitted yet, like you're alluding to. And in theory, you could say, well, this patient wouldn't have been held against you because they left AMA, but he really was adamant I don't think it had a lot of healthcare exposure. And I think being in the hospital mentally did not bode well with him. That's why he left AMA. Like, the whole thing, that there's a lot of psychological components to his journey from that standpoint. But
one of the shifts that I've had in my practice, and Jessica, I want you to kind of give your opinion and your clinical thoughts on this, is not just using this as an emergency switch for the patient that comes in that's a little bit volume up, that we want to keep out of the hospital, but also using it for our more chronic, quote, I don't like using the term stable heart failure, because I feel like these are very dynamic patients that are changing day to day. But what's your experience using for patients that have otherwise done pretty well? They're staying out of the hospital, to talk to them about saying, hey, this is something I think I would like you to have just in case.
So here in Florida, we have lots of retirees. We also have lots of cruise ports. So my patients love to go on cruises. So a lot of them, we talk about an emergency plan when they're on their trips. And I know cruises sounds funny, but the buffet, there's so much salty food. I've had several patients, they take it with them on trips. And they've had to use it a time or two, and they say, you know, this was the greatest thing that has ever come out for heart failure, because usually after their cruise, they end up in the hospital for 3 or 4 days. I also have a lot of stable, they've had heart failure 10, 20 years, and they're on all the GDMT, but they have a flare up. They maybe get a pneumonia every year in October, and then that throws them into an acute decompensation. And there's one guy in particular, he has these on standby for these times when he has a flare up, and he'll just send me a message through the chart. Hey, I'm volume up. I just want to let you know I used a Furosix. And then we'll just kind of keep an eye on him as time goes by to make sure he's doing okay, you know, he's still stable. And we will see him in the clinic very shortly after the acute decompensation when he feels stable enough can come in. And we do labs on site. We are attached to the hospital, so we do lots of lab follow-ups. And then I have chronic right-sided heart failure patients. They do this once a week. It's part of their weekly regimen. And I have a lady who had, I don't know, 12 hospitalizations in 2023 and all of 24 and all of 20, you know, a year and a half. She has not been admitted because the Furosix has been such a wonderful tool for her to have in her toolkit to treat her, you know, right-sided, you know, pulmonary hypertension, you know, fluid overload. So we have all kinds of different scenarios here, and I've been getting really creative with it. So
Wonderful. I remember when I first got out of school and, you know, took my first job in private practice cardiology, and someone said, well, what are you really interested in? And I said, heart failure. And they were like, you know, beta blockers and ACE inhibitors, right? What else, you know, how hard can it be? As we can see, pretty hard. It's I think this is a fun time to be in heart failure, regardless of how you're approaching it, whether it's from, you know, transition clinic, inpatient side, you know, heart failure transplant clinic, general cardiology clinic, preventative, whatever. Whatever angle you're attacking this from. But it's nice that we're walking around. Our toolkit is a little bit heavier these days than it was, you know, even 5 years ago, which is great. Jessica, how did you treat your little lady? So how did things kind of pan out with her?
So she's on minimal GDMT because of the soft blood pressure and the autonomic dysfunction and lots of hypotension. But she's been using the Furosix about once a week for the past 3 weeks. She's on a little bit of oral diuretic. That's all her blood pressure can really tolerate. But when she uses the Furosix, we've been having her use a little bit of midodrine just to help keep that blood pressure, just keep her hemodynamically stable.
Wonderful. The Viet, how is, and actually I should ask this for anyone, from a health systems approach, what does anybody using this at time of discharge? It's, I know in my health system, I'm kind of making, when the patient's going home, I'm kind of saying, calling my nurse and saying, hey, send this in for this patient so it's there when they're getting home. Or are you guys doing something similar? Do you have a discharge pathway? What's everybody doing for that hospitalized patient?
So this has been a hot topic. So our health system is pretty large and we have multiple campuses. And so we have one of our heart failure cardiologists who would really like to implement this as part of their discharge plan. You know, it's still new, so I'll say not everybody's super comfortable with it, but we do, when these heart failure patients are discharged, they're supposed to be into our heart failure clinic within 3 to 5 days after discharge. And I almost always, if they've had a recent exacerbation, get them set up with this so they have it at home. And we kind of have our game plan in case, you know, they get into trouble again.
Good.
And we're trying, actually, we've recently gotten successfully be able to do this and working on the contracting and other pieces to this, but we have worked to get this added to our part of our distribution process and policy, and be able to have some doses on hand for our meds to beds program. And knowing, and I know you can use the Furoscix Direct program and be able to get the pieces sent there, but we wanted to make sure that we had the ability to be able to give it to our team upon, or our patients upon leaving. We've been working with our local, not just patients as they leave, but our local SNFs, our skilled nursing facilities, and then having that available as their home bed to be able to prevent readmissions, because we do have a decent amount of SNF readmissions, and have been trying to pilot some of this work. And part of the effort is being able to send it to the SNF, because then they can consider it a home bed. And we've trained them on, knowing the patient's able to do that, and they can do that process there, and they work with us to get that. And so that's what our trajectory in that process is to do is. So
Now, what about in your ERs? Because we've been working hard to, like, some of our, term chronic heart failure patients show up in the ER on a Sunday afternoon. We're trying to come up with a protocol, like we give them a dose of IV diuretic, and then we had this idea to try to have some Furoscix stockpiled, and they could just hand it out in the ER and they could go home and do it again that night and then come into the heart failure clinic. But getting the hospital to buy in, it's been, I don't know, just an idea that's been thrown out there. I didn't know if any of you guys are doing
no, I
that.
think that will eventually be on our roadmap. Our next step with the ED is, so first and foremost, just to step back for the RED, we've had to get them like to the stage of like, let's actually use a real dose of diuretics. And that was like our big first goal and initiative. And like, we've gotten them, they're actually not just doing like 20 or 40 every time. We've gotten them to like do double and be okay with it. And so like, that was a big ordeal. And it was like one step at a time. And so our next kind of step is to get them to do some reg readings as well. And have people coming down there, our RT team, to help them do that and help us better triage. So to your point, that we can say, well, they can come to heart failure clinic the next day, or here's what this process is. Our first push was to like have them actually give a legitimate dose of diuretics when the patient shows up. So
you answered the
successfully been able to do that. So
I think hopefully you answered the anonymous attendee here that said any tools for ED providers, and I think that essentially you can't eat the whole thing all at once. This people are scared. I don't know why they use suboptimal doses, but in any case, that's the first battle.
Listen, we have gotten them over that hump. They are doing it great, and they're like they bought in, and I was like, okay, great. So that was a big win for us, because I mean we were just, it was just, and it actually proved to change our trajectory and our length of stay, obviously, because we started out getting aggressive diuresis on the front end. So
yeah, I mean, it'll be curious. I think, Jessica, if I'm not sure how it will work if you can actually order it and have it on hand in the ED. So this will be kind of the second question we have here from Katie. She's talking about how do we order the logistical part of ordering and facilitating Furoscix. Now, personally, I use the Furoscix Direct. I just, I like to just do things on my own. And so a lot of this resonates with me when I talk to patients. I'm like, if you want to do things for yourself, I like to do things for myself. And so using the Furoscix Direct. So I'm curious as to how you three end up ordering it. If it sounds like, Brian, you're having MAs kind of help you do that, but I like to do that myself.
Sure. I actually have done both. When I was in private practice, I, just put the forms in the room, and, as I'm talking to the patient, I just kind of filled it out and handed it to my MIA on the way out the door. I have I wonder if she's on this phone call. If she is, I'm going to give her props, because I think she said she was going to log in. But my nurse, Lily, is just phenomenal. I told her, I said, look, I can't stand another username, password. I love Furoscix Direct, but I'm not going to go in the portal myself. My nurse does it. It takes her 30 seconds. It's out the door. She can track it, which is even better. So I'm the other thing is, which is comforting to me, and I was actually telling someone this yesterday evening that was kind of on the fence about using Furosix, as I said, I can give somebody a sample in the office today, and I know they're going to get another one tomorrow. So I know I'm at least going to be able to treat that patient with 2. I'm going to get them out of this danger zone today with 2 treatments, because they're going to get that free one.
Yeah.
And I think that's the, I think I'll give kudos where kudos is due. I mean, for SC Pharma is making sure that patient is getting treated. So
well,
that's
to your point, one of the things with us having it on our shelves in our pharmacy at this particular juncture, and the work to do that is we use our med access tech, because our heart failure clinic's at a hospital outpatient department. It's at HOPD, right? And so in theory, I can order beds to beds to it.
Yeah.
From that standpoint. And so because of that, we are able to do the process where our med access techs are able to do a lot of the benefits works and investigations. So we're not having to do all the logging. And I was like, to your point, Brian, I was like, I'm not going to do Furosix Direct, and no one's going to do it. And it's not that it's a bad process, and it's very good to discredit it, and if it works for people. But I was like, I need something that is just like the normal workflow for us, because otherwise it's an added step. You know what I mean? So.
And I think you're looking on a much larger scale than like someone like me, who is, this is not my main thing. Heart failure happens to my patients, but it's not what I manage.
Sure.
If I was doing it on a larger scale or common, then I would not be doing Furosix Direct.
Yeah. Have you been able to, one of our viewers, have you been able to link your notes to attach to Furosix Direct site? I'll have to ask my nurse. I have no idea.
Yes, my nurse does it, and she links to it. Yep.
Okay.
We don't do Furosix Direct. we like I said, once I got it, I was like, well, we'll just do our benefits investigations that way and do it. So.
And if you have Epic, it's really easy to link everything.
Yeah.
The but at least in anecdotally, I think we can all speak. It's very rare that we're finding folks that can't afford this. It definitely, like anything new, it kind of started a little bumpy, but it's very often we're getting. I know, at least where I'm at, I see a lot of Medicaid, I see a lot of Medicare, I see a lot of managed Medicare. TRICARE and VA patients are a big consideration. I know that's something that the company is working on some of those negotiations with some of the payers for. But at least the majority of my population being Medicaid and Medicare Advantage type managed Medicare plans is it's great to be able to hear the patient come back and say $0 copay, $0 copay, $0 copay. So I think we're getting people covered. Is that your experience as well?
That's been mine, and in large part, anyone that I order it for is in the Medicare, Medicaid kind of side of things. I haven't really used it for consumer, I guess.
Commercial.
We've had luck getting commercial payers.
Yeah,
excellent.
Yeah. I've got some commercial, but you worry about these, the Medicare with these caps and this and that, and how much they've got to spend, and the marvelous ways our government works. Just making sure that they're able to afford it.
For the meantime.
Yeah, for the meantime, at least.
But Jessica, I'm so glad to hear that. I saw your thing. I'm like, Watchmen, and it's guys.
Watchmen was going off in my head too.
Like,
the Viet, I think it was your case. Just out of curiosity, because your lady had permanent AFib, prior failed ablations. Did she have any conduction abnormality? I mean, was there any indication to, we're not really talking about diuretics here, but the first thing that popped in my head was, could she have gotten a device for her AFib? Like a nodal ablation and a CRTP or something?
Yeah. You know, no, I mean, her QRS is normal.
Okay.
So I don't, CRT would not have been helpful. She's HFpEF, so it's not like she'd had taken a hit and then just widened or anything like that. No other conduction abnormalities other than AFib. And
Okay.
so it doesn't help, of course, to have HFpEF and then AFib. As you'll see, Cabana is going to come back around and look at HFpEF. In that space, but in any case, atrial fibrillation just kind of messes up any type of atrial kick and that additional volume that they need. So yeah, can't solve for that for her. But yeah, no indication for AV-NRT or not AV-NRT, but AV nodal.
Yeah, I was just thinking, you always wonder, try and do anything you can for those people that the AFib's just kind of feeding the fire, so to speak.
That's what's happening with my lady, but I had to get everybody on board to see what we can do to treat that. So
well, we're 4 minutes over 8 o'clock, so I don't want to keep anybody too long. It's a Tuesday night. I know everybody in various time zones, joining us this evening. Thank you very much to all of the panelists, Craig, Viet, Jessica, definitely heavyweights in the heart failure space and in your own respects. So thank you very much for giving us an hour of your time this evening to give us your perspective on diuretics, something that sounds so simple, but really is not. But hopefully this is a tool that I hope our listeners can take away and adopt. And I think our panel shows the versatility of cardiology providers we have here, and that you don't have to be in a heart failure clinic or a transplant clinic or an academic center per se to be able to use this. We've got community-based cardiology, preventative cardiology, transition clinic, heart failure clinic, pulmonary hypertension. Everybody's kind of well represented who's using this to their patients' betterment. So, of course, feel free if there's any questions that pop up, please send them on the APAC website. We'll be happy to distribute them. But thank you all for joining this evening, and have a good evening.
Thank you, everyone.
Thank you.
Thank you.